Consistently good. And we welcome you all for this meeting. And as usual, we have two good presentations awaiting for you for this Saturday night. And one from Madras Medical College, who is going to present an interesting case of PTLD, and it's a odyssey of complications. And I'm sure that it will be more exciting. Presenting this first is, title is Dr. Mithun is a postgraduate from finally a postgraduate student from nephrology MMC and ably guided by Dr. Jayalakshmi Madam. Jayalakshmi Madam, as you all know, she is active member of WIN, that is Women in Nephrology Group, and she completed her DM 2 decades back, and she's a very soft-spoken yet wise woman with a lot of experience in nephrology. Particularly, she had a very good academic exposure in MMC, and I hope she will add more insights into the case. Welcome you, madam, for this meet. And
Thank you.
we have a second presentation to be done by Dr. Nitya, and she is the daughter of one of the doyen of South Nephrology, Dr. Dinagaran sir from Madurai Kidney Center. And she's being ably assisted by Dr. Shivakumar, who is also a nephrologist and at Madurai Kidney Center. And she's an active member of BIN, and she has volunteered herself to present this pregnancy in post-renal transplant. And we can go sail across this topic because it's more important from the patient's point of view, how to get pregnant and what are the maneuvers we have to do. And it's going to be a lot of interesting stuff from her. And welcome you, and we hope that you will give a lot of insights into this topic. And to make this session more interesting, we have two eminent panelists, and they cannot be unparalleled academic excellence. One is Dr. Umapati Ekdesa from is a vice chairman of Nephrology Institute of Nephrology, Nadir Mujilbhai Patel Urology Nephrology Institute, Nadir. And I had a privilege of seeing his work. And when I did my DM in 2013, when I visited his institute, and his rounds and sharp comments and is being always been carried for the past decade. And he's an active participant in our peculiar case series group. And his remarks and his explanation and his answers for the questions posted by the members of the group is outstanding. And he's very short and crisp, and he will talk to that point actually. And he had a lot of presentations. He has trained around 50 DM postgraduates, and he has a lot of interest in transplant intervention nephrology, and hope that he will have a lot of insights into these cases. You would have seen many cases, and whatever complications you say that you would have crossed and you would have discussed, and hope that he will give a lot of insights in this case. And welcome you, sir, for this meeting. And joining him is Dr. Ram Prabhakar. He's an alumni of Madras Medical College, and he has been a practicing nephrologist, one of the busy and well-known nephrologists of Chennai. And he has been currently working in SIMS, that is Institute of Medical Science, Vadavani. He is the director of the Institute of Nephrology there. And he's a well-known academician, known for his presentation skills. And his presentations always being welcomed and adored by many. And he had a good academic excellence, and he had already came to our meeting twice before, and his remarks and everything is perfect to the point. And he has a unique combination of administration of CS, passed his MBA, has a degree of MBA, so he can add many business point of view from this healthcare part also. I happened to hear his talk on hyperkalemia. He has to put how much industries, pharma industries, pumping in for this Bactromer and all. And that was very much exciting. He thinks out of the box about things. So welcome you, sir, for this meet. And you both will definitely add more spice to this presentations for these meetings. Without wasting much of our time, and we ask Dr. Mithun to start his presentation. And at the end, we'll have a discussion. Thank you. Dr. Mithun, start your presentation, please. Mithun, you are not audible. Dr. Mithun?
Hello, sir. Hello.
Yeah.
Hello, sir. I am audible, sir.
Mithun, you must be a little more louder, Mithun. It's not clear.
Hello, it's audible, ma'am.
Now it's audible. Yeah, maybe you can keep the mic close to your to you.
Yes, ma'am. Yes.
Yeah, now it's better.
Good evening, Sharon, ma'am. At this juncture, I take this opportunity to thank organizers Dr. Rajarajan sir and Dr. Velaravan sir, who I look upon since my residency days, and my mentor and my professor Dr. Jailishmi ma'am, and panelist Dr. Ram Prabhakar sir and Umabari sir. Going into the case, this is about a 29-year-old gentleman, Mr. K, who is a resident of Tiruvallur near Chennai, studied up to ITI, received, he got transplanted, ABO compatible transplanter with father as donor on 16/11/2017. Both the donor and recipient were A positive blood group. The patient was on maintenance hemodialysis for since 6 months before transplant with a net urine output of 400 ml per day with with native kidney disease suspected chronic glomerulonephritis.
Mithun, your slides are not moving. Dr. Mithun?
Mithun?
I think he's lost his connection, I think. Mithun?
Yeah, he's not to be seen at all. Mithun, are you there?
Dr. Mithun? I think he's lost his connection. Mithun? Dr. Mithun?
Yeah, I just spoke to him.
Yeah,
I asked him to check his connection.
Yeah. I think hopefully he's getting the connection back.
Hello.
Dr. Mithun?
Mithun?
I think he's Mithun? Okay.
Hello, sir. Hello.
Dr. Mithun? Are
sir,
you there?
is audible, sir?
Yeah. Make the connection perfect and just go ahead, please.
Sir, it's clearly my slides visible, sir?
Yeah. Go ahead, please.
Yeah, sir. His induction agent used was Besiliximab 20 mg IV on POD on day of surgery and post-operative day 4. The intra-op events was uneventful, and he was discharged with the creatinine of 0.9 and POD 9 with on triple immunosuppressants, that is TAC 5 mg and azathioprine 100 mg and prednisolone of 25 mg OD. He was Mr. K was happy post-transplant 6 months. He was a CNA, his metabolic status was found to be poor CNA metabolizer, and his graft was functioning well with the creatinine of 1 mg per deciliter. His tax levels were adjusted based on his trough levels, and he was on 3.5 mg around July 2028, which is post-transplant 6 months. Since post-transplant 6 months till post-transplant 5.5 years, he had a series of recurrent infections in the form of pneumonia. At the time of post-transplant 6 months, he was diagnosed to have Klebsiella pneumonia and was treated with sensitive antibiotics, and was and his discharge creatinine was found to be 1.2 mg per deciliter. His tacrolimus per day dose was 3.5 mg. Post-transplant 7 months, he once again had a recurrent pneumonia, and was however, his sputum analysis was found to be negative, but the radiological investigation was positive, and he was treated with appropriate antibiotics and discharged with a creatinine of 1 mg. And a similar infection around the post-transplant 1 month, 1 year and 1 month with the Klebsiella. Post-transplant 1 month, 1 year and 3 months, he had again an infection of Pseudomonas, and he was treated with meropenem for 14 days with antifungals and discharged with creatinine of 1.3 mg per deciliter with TAC levels of with tacrolimus of 0.5 mg per day and azathioprine. At post-transplant 1 year and 4 months, he was infected with intestinal amoebiasis and had acute gas dysfunction. However, on treating with antibiotics, as a creatinine came to around 1.5 mg per deciliter, and his tacrolimus was adjusted based on his trough levels to 0.5 mg per day. Post-transplant 1 year and 4 months, he once again had a pneumonia infection, and since he had a recurrent pneumonia infections, he was started on modified ATT and discharged with the creatinine of 1.3 mg per deciliter. Our post completion of empirical ATT for 10 months, he had creatinine of 1.3 with a TAC level of 0.5 mg per day, and his tacro level at the time was around 8. Post-transplant 4 year and 10 months, he was diagnosed to have H1N1 positive on RT-PCR and was treated with anti-flu agents for past 2 weeks. Here, his imaging status was found to be normal. It is post-transplant 5 year and 2 months. He was diagnosed to have stricture urethra, which was a traumatic event because of which was a traumatic event due to Foley's catheterization during his previous admission. At the time, his creatinine was around 1.4 mg, and his tacrolimus was 0.5. His tacro dose was 0.5 mg per day. Post-transplant 6 years, and following that, post-transplant 6 years, his stricture urethra was addressed with optical internal urethrotomy, and he was post-transplant 6 months. He was subjected to buccal urethroplasty with a functional graft of creatinine of 1 mg per deciliter and tacrolimus of 0.5 mg per day. It is around post-transplant 7 years and 5 months. He got admitted under medico-gastroenterology with the complaints of history of abdominal pain, constipation. On evaluation, his OGD-scopy was found to have erosive gastritis, and he was treated with H. pylori kit for past 2 weeks and discharged. However, his symptoms doesn't improve, and he once again got admitted on June 2025 under our nephrology unit, which is around post-transplant 6 months with the complaints of abdominal pain for 1 week, constipation, nausea, and vomiting for 2 days, with the melena for 2 days. On evaluation, his stool occult blood and bone cysts were found to be negative, and his USG abdomen relieved a relatively well-defined hypoechoic lesion of 4.2 into 8 centimeter in left lumbar region with some vascularity. On further investigation, his EGA-scopy showed a proliferative growth in D3 segment of duodenum. His colonoscopy was found to be normal. So we proceeded with CT abdomen, which showed a finding suggestive of Cori interception. So we subjected him to a contrast study, which showed a well-defined enhancing lesion of 6.7 into 3.7 centimeter in the mesentery at the L3 level in left lumbar quadrant, which encasing a branch from SMA with compression, with the multiple polyps of varying size in the duodenal and jejunal loops, largest measuring 4.3 into 3.7 centimeter in the distal jejunal loop. Further, biopsy from the proliferative growth in the D3 segment of genome showed a atypical cellular infiltrate suspicious of a cancer. This immunocytochemistry found was suggestive of a diffuse large B-cell lymphoma, high grade of ABC type. On further investigation, if peripheral smears are found to be a normocytic normochromic anemia, and its viral panels were found to be negative with bone marrow showing trilegion hematopoiesis with hyperplasia with 5% blast and megakaryocytes. We obtained oncologist opinion on 16/6/2025, and we initiated him on CHOP regimen, which is cyclophosphamide 1 grams and doxorubicin 60 mg, vincristine 2 mg, and prednisolone 60 mg from day 1 to day 5. Post chemo, he had a symptomatic improvement in the form of relief of abdominal fullness. Since post chemo, on day 1, he had numbness and paresthesia of both hands. On day 2, he had parapheresis of bilateral overlap, proximal and distal. On day 3, he had a areflexic paraplegia. The lesion progressed to areflexic paraplegia with orthostatic hypertension. On day 4, he had autonomic dysfunction in the form of constipation and urinary retention, and his post-vital residual urine was found to be 500 cc, which further progressed to him to a respiratory paralysis, and he developed a seizure. And we have 4 seizures and a respiratory paralysis. We mechanically ventilated him. Neurologist opinion was obtained, and the imaging showed normal study with the CSF analysis showed acellular proteins and sugars were within normal limits. And we have done him on a video, put him on an NCS study which showed axonal neuropathy, and his fundoscopy was found to be normal with no evidence of papilloedema, and his extraocular movements were almost normal. So what is this case? It's a case of live-related renal transplant, AB1 compatible transplant, developed post-transplant lymphoproliferative disorder, which is diffuse large B-cell lymphoma. We put him on CHOP regimen, and he developed acute encephalopathy, which is acute symmetric flaccid quadriparesis with autonomic dysfunction. This is his investigations since his admission. Post chemo, that is around 36 post chemo, he had a significant pancytopenia, which we thought probably could be due to the intense immunosuppression. Because of this chemo, he developed this. Since his admissions, his graft was functioning well till 1/7/2025. His creatinine was around 1 towards end. This is 3, 4, and 4/7. He developed acute grid function, but his urine output was around 4.5 liters to 5 liters per day. His cultures was found to be negative. His echo and chest X-ray was found to be normal. During this admission, we had transferred him on 4 units of leukodepleted PSBC for his anemia. So what is we entitled ourselves to this 4 differential for this gentleman, which is neoplastic infiltration of nerve roots, paraneoplastic neurological syndrome, axonal GBS, and acute meningoencephalitis. Going into the first differential, which is a neoplastic infiltration of nerve roots. The patient didn't have any neuropathic pain, and his CSF analysis was found to be negative. We couldn't proceed with the MRI of brain and spinal cord since he was very sick and mechanical ventilated. And further, post chemo, he had a remission in the form of reduction. The form of reduction in the tumor size, but we couldn't confirm it with the radiological, that is USG. But he had symptomatically improved. He had a reduction in this abdominal fullness symptom. So we thought this differential could be unlikely. Going to the second differential of paraneoplastic neurological syndrome, we have done him on a paraneoplastic antibody profile. which was found to be negative. Further, it's a purely a sensory involvement, but the patient had motor, sensory, and even autonomic dysfunction. So we thought this the differential could be unlikely. Going to the third differential, which is axonal GBS, we ruled out with these following parameters that there is no any absence. There was an absence of clear infectious trigger, and there was a sense even cultures were negative, and its antibody profile was found to be negative, and he also poorly responded to IVIG. We couldn't proceed with MRI. CSF analysis was also negative. There is no any albuminic cytological dissociation. So we thought this differential could be unlikely for him. We ruled out this even acute meningoencephalitis, since his CSF analysis was yes, there's no history of fever, cultures turned to be negative. We thought this could be unlikely. This is based on this 4 differential. We started him on IVIG of 0.5 grams per kg for 5 days, and his TACRO was reduced to 0.5 mg OD. He was treated with meropenem, vancomycin, antivirals, steroids for 3 days, and injection romiplastin, filgrastim, B12, and thiamine. Since he had a seizure, we put him on injection Levipil and antifungals tablet oriconazole, and he was on inotropes support. However, we couldn't save him. He succumbed to his illness post chemo 1 week. So we thought what we are missing. So we retrospectively literature search where we could find this entity called as fatal vincristine induced acute neurotoxicity. This first one is a patient from Morocco. It's a patient from Morocco with a similar picture to our patient. And the second article is a systematic review of 71 patients from Denmark. And third one is the patient from Spain. It's published. It's an European article published in a neurological journal. So, what is this vincristine-induced acute neurotoxicity, which encompasses these following features? In our patient, the patient had a sensory disturbance in the form of paresthesia and numbness on day 1, and he had a motor weakness and walking difficulties. And on day 4, he had constipation, urinary retention. He had orthostatic hypotension. Finally, he progressed to respiratory distress, and he had a seizures and mental changes too. Some light on vincristine neurotoxicity. Sorry, what? Some light on vincristine. What this drug exerts its antineoplastic effect by inhibiting the polymerization of tubulin and incorporation into microtubules, which prevents mitotic spindle assembly, leading to extension of mitosis and thereby apoptosis. Vincristine has been linked to the development of sensory motor axonal neuropathy, autonomic neuropathy, and cranial neuropathy in a dose-dependent manner, usually around 4 mg. But in our patient, we gave up to 2 mg. This vincristine-induced neurotoxicity is more pronounced in lymphomas than non-lymphoid cancers. This vincristine interferes with microtubules, which are critical components of nerve axons, functioning as tracks for vesicle-mediated transport and leads to axonopathy. Vincristine is primarily metabolized by Hello.
I'm with him. Go ahead, please. You're audible.
Yes, sir. Vincristine is primarily metabolized by this cytochrome enzymes A4 and EF5, and this fluconazole and voriconazole inhibit this action of this cytochrome enzymes. Voriconazole inhibits the P-glycoprotein efflux pump, a vincristine transporter, resulting in higher intercellular vincristine concentration. And vincristine induced neurotoxicity is further enhanced by this colony stimulating factor. This patient was on we put him on voriconazole, and we gave him on romiplastin, filgrastim, which could potentiate this action of this vincristine, even though its accumulated dose based on this article was 4 mg, but he received only 2 mg. But these could be the contributing factors for enhancement of this vincristine-induced neurotoxicity in this patient. How do we find vincristine toxicity? There is no any area where we couldn't measure this vincristine level. This vincristine levels are measured by similar to MMF by area under curve. But however, that is not the definitive thing, because this drug has an extensive large volume of distribution in our body. So AAC may not reflect the drug levels in the blood. This is mostly by vincristine-induced neurotoxicity is mostly by this scale measurements, that is WHO's peripheral clinical, based on clinical findings only we can suspect this. That is by WHO's peripheral neuropathy score and common terminology criteria for adverse events, which was from widely used in neuropathy gradient scale. And it is from total neuropathic score and pediatric modified total neuropathy score and quality of life questionnaires to access chemotherapy induced neuropathy. Is there any treatment and preventive measure to reduce this vincristine-induced neurotoxicity? Various studies have involved this following drugs such as gabapentin, pyridoxine, pyridostigmins, and glutamic acid, glutamine, folinic acid, acetyl L-carnitine, and amifostine. However, these are small studies. Still, their role in preventing this toxicity, neurotoxicity, is questionable and debatable. Thank you. Hello, sir.
Thank you, Dr. Mithun, and nicely worked up case. And sorry for the patient who could not make it up, but it's really a new entity. And Dr. Jayalakshmi, madam, your comments, please.
Yeah, actually, this patient, as soon as we had the patient, he had that lymphoma, which we were really worried, because until then everything was going on well, even though he had a few infections in between. But then the chemotherapy was started, and we were actually searching for paraneoplastic syndrome only, because vincristine was quite a small dose that was given, and his graft function was initially good. But then this patient has actually had a typical picture of vincristine neuropathy, but that was actually potentiated by the use of azoles. And the metabolizer status of the patient also comes into play when we give drugs like vincristine, which are metabolized by the CYP. So actually, it was a posthumous diagnosis for us. We lost the patient, but we learned a very important thing is that any new drug that you add to the armamentarium, you should always check it with each and every drug the patient is taking. It's very, very important. So that actually we have to have a ready reckoner, and we have to check it whether we are going to have any interactions, and then look on those lines. Probably if we had, I don't know whether we would have saved the patient, but we would have been able to diagnose and at least try some of those experimental drugs that have been used for the vincristine neurotoxicity. So this was a learning case for us, and sad that we lost the patient. We just wanted to emphasize the importance of drug interactions in renal transplant recipients, which is very, very important, because they get into a lot of issues. They need a lot of antibiotics. And when they get malignancy, they need a lot of anti-cancer agents. So the interactions is very, very important that we will have to look into.
Thank you, madam, for your comments. Dr. Umavati, sir, your comments, please, your experience on this.
Very nice case. But again, sometimes it is difficult to treat. I don't know whether EBV positive or EBV negative.
EBV negative, sir.
EBV positive, you have shown PBP positive.
Sir, it was EBV negative.
Okay. So EBV positive people go with rituximab. I think all this could have been avoided. But if it is negative, then go for a CHOP. Again, as madam said, each drug we use, we need to see the drug interaction, and we need to sometimes it gives a very, very alarming situation where the drug interaction, because voriconazole is most of the oncologists use either acyclovir or other things, and also the antifungal agents along with the chemotherapy. So I think it may be sometimes we have to check, because cyclosporine and other things are also going on. The drug interaction has to be taken into consideration. So I don't know whether they could have replaced vincristine with some other thing. I really don't know. So.
Okay, sir. Dr. Ram Prabhakar?
So again, thanks Raj for the opportunity. I think nice to meet you after a long time. So few things were interesting as I went through the presentation. I also wanted to know a few things from the presenting team regarding why they have chosen azathioprine over mycophenolate mofetil in this patient in this era. Because what I have found after going through the literature is there is a population-based cohort study which says the incidence of PTLD is higher with azathioprine compared with mycophenolate mofetil. I was also kind of know this after I went through the literature again. And I was again stunned to see this patient continue to have repeated infections. He's a poor metabolizer, continue to have very high tacro levels. I don't know how they could manage it. It's very tough in a given patient, I understand. But is there any attempt to convert to long-acting tacrolimus, or how did they manage? Because it was continuously high. Then what they have done with immunosuppression in presence of CHOP? Also, I wanted to learn from them that what did they do with CHOP? I know it is an unfortunate end. But again,
they've reduced the TAC into 0.25 OD. That's what they had.
But they have added voriconazole. That is another problem. That should have definitely. Then again, cause of death in a patient like this, I think it should be sepsis than vincristine-induced neuropathy. Yeah, it may be a definitive this diagnosis there, but I feel considering the pancytopenia and other things, I think it should have been an sepsis as an end. These are all my just observations.
Definitely, sir. Yeah.
Yes, Ram, actually, with the chemotherapy, the pancytopenia and sepsis is something which we could not help. And the Rohilast was also given, which actually had potentiated the effect of vincristine. And the ultimate death would have been due to sepsis, because with vincristine, the patient had to go in for a ventilator. And that also would have, it's one of the high risk factors for sepsis. So all these things, ultimately sepsis must have been the reason, but we just wanted to highlight the vincristine neurotoxicity in this case.
Yeah, madam. What I understand from that, actually, vincristine neuropathy classically produces axonal neuropathy. That is one point. With the patient was also having axonal neuropathy, pointing towards this is mostly due to vincristine. And do they have any relation that vincristine toxicity enhances with your poor metabolizer status, and patient is poor metabolizer, no, madam, actually?
Yes. Actually, the poor metabolizer status augments vincristine neurotoxicity. See, all these things we learn because we only look at tacrolimus for the basically to look at tacrolimus levels, we use the metabolizer status. But that has a say in vincristine metabolism also. So probably that is one reason why the neurotoxicity has been pronounced in this case. So that's why I said the metabolizer status should be applied to other medicines which get metabolized in the similar pathway.
Okay. And one interesting point is, among the antifungals azoles, fluconazole has a high preponderance to increase the vincristine level. Itraconazole and voriconazole. Fluconazole has a lower incidence of vincristine.
Actually, we use voriconazole as the antifungal. Fluconazole is not that, effective, isn't it? So we never thought about this interactions. That actually we missed.
Okay.
I don't know if it was known whether people could have used an IL-1 blocker. I mean, people have seen that it may prevent it, but again, it was a retrospective diagnosis. So.
Yeah. Umar, sir, coming into the PTLD, what is your experience and how it goes at a CHOP regimen? In any other regimen you try?
Most of the things what we've seen were EBV positive. So they used rituximab and then maintenance therapy of 3 to 4 doses. And then they have given the CHOP regimen if it persists. So PTLD is again, PTLD, they see that if it is an EBV positive, they go for rituximab. If it is negative, they go for CHOP. And again, if it is stronger, then they go for even a CAR therapy also. So it at all depends how exactly, but we are seeing much less PTLD, to be honest. And we are seeing more of a liver related pathologies and stomach related pathologies for others.
Okay. Dr. Ram, your experience on PTLD?
So again, as Sir pointed out, the incidence of PTLD appears to be kind of reducing nowadays. I don't know the reason, but that has been an observation. Again, when we came across PTLD, we classify them to early onset and late onset. Whoever has an early onset PTLD with EBV positivity, they all did well with rituximab. That is our experience. I think we had only 2 patients who had a complete remission with just rituximab therapy. On the other hand, we had late onset PTLD, which has been given CHOP. All these patients did not do well. They behaved like your regular lymphoma patients and they did not do well. So that is where, I mean, the EBV comes a role, and that is the timing of onset also makes a.
Right.
One of our patients, after 12 years after transplant, so he underwent a CAR therapy. So, but again, it was very, it cost, he went to US and get it done. It was an EBV negative patient and he was financially sound, and he underwent a CAR therapy, which he did well, almost for around 3 to 4 years. And after that, he had an infection. So it is, but again, everywhere it is not available and the cost is very humongous.
Yeah. So we don't have any questions from the chat box. And one other important thing, you would have searched literature, Jayalakshmi. Is there any ways to prevent this vincristine-induced neurotoxicity? Is there any other drug that can give?
Any IL-1 blocker has been used to prevent it.
Yes.
Anikera, but again, it is, that's what I said, it is retrospective. So prospectively, whether we can prevent it, but again.
Okay, good. Thank you.
And not using, you said use fluconazole instead of voriconazole.
Yeah. So it's all literature-based evidences, and also I could find that molsidomine. This is one drug which activates guanylate cyclase, but by reducing the vincristine-induced peripheral neurotoxicity. That is for primary prevention of this, but I don't think so. It is available in India now. So if there are no further questions, and already we have crossed 5 minutes late. And thank you for the presentation, madam. You have done a lot for this patient, and your workup is fantastic. And sorry for the patient who could not make it up. And thank you for presenting and giving light to that vincristine-induced neurotoxicity.
Thank you, Rajarajan, and thanks to have a good number of inputs from the chairpersons as well. Thank you for the opportunity.
Thank you, madam. It was very nice case, and it is eye-opener to use drugs with caution.
Yeah. Thank you very much.
Thank
and
you, sir.
We'll go on to the next case. Dr. Nithya, please start your presentation.
Thank you, sir. Yeah, I'll just share my slides.
Yeah.
It's visible, sir?
Yeah. Full screen. Make it as a full screen, please.
Is that okay?
Yeah. Go ahead.
So thank you, Dr. Rajarajan, sir, and Velagan, sir, for giving me this opportunity. So I'll be talking on post-renal transplant pregnancy. I just have a case snippet, which Rajarajan, sir, was very kind enough to share with me. So after that small case presentation, I'll be going on with the topic. So the case snippet is of a 20-year-old female, Mrs. K, blood group B positive, native kidney disease of CGN. She underwent a preemptive transplantation with mother as donor. Mother was also B positive and the donor was 43-year-old. The HLA was a haplomatch and the CDC cross match was negative. The transplant was done on 16/11/2017 with no induction, and she was started on triple immunosuppression, TAC, MMF, and steroids. The discharge creatinine was 1 milligram per DL. And from 2017, 2023, the pregnancy was planned. And once the pregnancy was planned, MMF was switched over to azathioprine. Pregnancy was confirmed in October 2023. There was no maternal risk factors, and she delivered by LSES, a female child of 2.8 kg. The graft function was normal throughout the pregnancy and postpartum, and her latest review was on August 2025 with a creatinine of 0.79. So it was a successful pregnancy post-transplantation in good hands. So my topic, I'll be going through these headings. So the current knowledge, from where do we get the source of information of pregnancy post-renal transplant? The registries include the National Transplant Pregnancy Registry in the UK, the European Dialysis and Transplant Association Registry, and one registry in Australia and New Zealand. There is one National Transplant Pregnancy Registry which is active presently in the United States. Other than this, there's not much of data. So historically, the first successful pregnancy in a kidney transplant recipient happened in 1958. It was for a lady named Edith Helm. She underwent a renal transplantation with her identical twin as a donor in 1956, and she delivered a healthy full-term boy baby by cesarean section. So how is the sexual dysfunction? How is the sexual function in a patient with CKD, and what happens during HD, and then what happens after transplant? When the patient is having a chronic kidney disease, there are a lot of hormonal imbalances. There is abnormal hypothalamic pituitary ovarian axis. And because of this, most of the CKD women and girls who come to us, they come with menstrual irregularities. They have anovulation, decreased libido, and impaired fertility. And most of them also go in for an early menopause. Even on dialysis, these people have menstrual irregularities. Most of them are amenorrheic during the phase of dialysis. Women with ESRD, they have a high serum prolactin due to impaired renal clearance. They have an increased luteinizing hormone levels and follicle stimulating hormone levels. They have reduced estradiol and progesterone concentration, and they have anovulation due to these persistently elevated hormones. So what happens post-renal transplant? The fertility is restored. There is return of the circulating sex steroids to normal range within 6 months after a successful renal transplantation with a good graft function. So contraception should be initiated early. So what happens to the pregnancy in the presence of an allograft? Normal physiological change of pregnancy to the kidney, there is hyperfiltration, there is intrarenal vasodilatation, and increase in effective plasma flow. There's increase in GFR by about 50%, and there is a decrease in serum concentration of creatinine and urea. So what happens to the renal allograft? How it adapts during a pregnancy? There is increase in creatinine clearance of approximately 30% in the first trimester, and this increase is sustained in the second trimester with just a small dip, and it returns to pre-pregnancy levels during the third trimester. And what happens to proteinuria during pregnancy? Allograft recipients have a higher 24-hour urine protein excretion compared to healthy women. This protein excretion is increased throughout pregnancy, and it returns to pre-pregnancy levels at 3 months postpartum. And there is increased risk of other comorbidities like urinary tract infection and preeclampsia. So what are the risks of maternal complications? Maternal complications like hypertension and preeclampsia are high in a post-transplant pregnancy. Hypertension is reported to be incident in 52 to 69%, and preeclampsia from 24 to 38%. There is a sudden worsening of hypertension and proteinuria, which may be an indication of an acute rejection. And how to manage? Antihypertensive should be initiated if the blood pressure is consistently higher than 140/90. Now we know the safe drugs. And low-dose aspirin reduces the risk of preeclampsia. And there is also an increased incidence of pregnancy hypertension, which is defined as systolic BP more than or equal to 140 and diastolic BP of more than or equal to 90. Post-transplant hypertension is an independent risk factor for pregnancy complications. Oral labetalol or methyl dopa are mostly used. We cannot give AC and ARB as they are contraindicated in pregnancy. And preeclampsia incidence is also increased. And there is also an increased incidence of thrombotic microangiopathy in a pregnant woman post-renal transplant. How do we monitor the kidney function? We have to monitor for serum creatinine and proteinuria very closely. And if necessary, we can even do a renal biopsy in some selected cases. There is an increased incidence of diabetes and gestational diabetes in a post-renal transplant pregnancy. So all women with gestational diabetes should be given nutritional counseling, and also insulin therapy is required in 15 to 30% of patients. So the risk factor, pregnancy without any risk factor will not have an increase in rate of graft loss. So it will continue as a pregnancy in a normal individual. What are the risk factors? It includes the history of drug-treated hypertension, a pre-pregnancy creatinine of more than or equal to 1.4, and presence of proteinuria. So risk of rejection, it is safe to perform an ultrasound-guided allograft biopsy during pregnancy if we suspect a rejection. High-dose steroids are the first-line treatment for allograft rejection, and the rate of rejection is not increased during pregnancy or postpartum. The risk factors, if present, the risk of rejection is also high. The risk of infection is high, as in UTI. There is a high risk due to the use of immunosuppressive medications. The screening for UTI should be performed regularly, and asymptomatic bacteriuria should also be treated with antibiotics. The risk of viral infection should also be taken care of, as CMV infection can be transmitted to the fetus. Herpes simplex infection is associated with increased risk of abortion, and infants born to mother with hepatitis B should receive immunoglobulin and vaccine. So what are the other obstetric complications? There's a higher incidence of cesarean section compared to the general population, and majority of the cesarean, the indication will be a fetal distress. Then there is a higher incidence of diabetes. It ranges between 3 to 8%. The risk of fetal complications, pregnancy outcomes, the rate of live birth is comparable to the general population, but still there is a higher incidence of preterm delivery, low birth weight, and intrauterine growth retardation. And the rate of miscarriage ranges from 11 to 26%, and no high risk of perinatal mortality is observed in the absence of risk factors, which I've already mentioned. What are the predictors of pregnancy outcome? Poor pregnancy outcome in a patient with hypertension, if the pre-pregnancy creatinine is more than or equal to 1.4, presence of proteinuria, and history of a second or a third renal transplant. Successful pregnancy outcomes if the creatinine is low in the absence of hypertension and minimal proteinuria and younger age. What is the optimal time to conceive? So what are the guidelines and recommendations? The American Society of Transplantation recommends 1 to 2 years post-transplantation, and the European guidelines recommend delaying pregnancy up to 2 years after transplant. It is safe to conceive after 6 months if the graft function is stable and women are not on teratogenic medication. There is a higher likelihood of viable fetus outcome when conception is within 2 years of transplantation. So coming to the immunosuppression, which are safe and which are not safe during pregnancy, the relatively safer options are glucocorticoids, CNIs, azathioprine, mTOR inhibitors. ATG is safe, and belatacept is safe. Glucocorticoid, it crosses the placenta and it is metabolized by the enzyme mentioned. There is minimal risk of oral facial cleft defects. Moderate doses are unlikely to interfere with early life programming. CNIs do cross the placenta and are influenced by the P-glycoprotein activity. Relatively high number of premature births are reported, but the long-term effects need further evaluation. Azathioprine does not produce any teratogenicity because the placenta is a barrier for 6-mectopurine, but there is a higher incidence of prematurity and low weight. But the use in pregnancy is considerably safe. mTOR, there are animal studies which show adverse effects, but episodic reports of successful pregnancies are also there. ATG has been successfully used to treat rejection. It is relatively safe, with side effects mostly relating to allergic reactions. It is not mostly teratogenic. Drugs with uncertain safety, rituximab and eculizumab. Rituximab crosses the placenta. It increases the risk of B-cell depletion. Retrospective study showed high rate of miscarriages. Administration is discouraged unless benefit outweighs the risk. Eculizumab is a selectively transferred across the placenta, high rate of fetal survival and low rate of maternal complications, administered only if the benefit justifies the risk. So drugs with fetal toxicity, MMF is toxic. It is associated with increased risk of congenital malformations and pregnancy loss. Women should have a negative pregnancy test before starting treatment with MMF. If pregnancy occurs, MMF should be stopped. Bortezomib causes embryo-fetal lethality in animal studies. Control data in human pregnancies are unavailable and the use in pregnancy is not recommended. Cyclophosphamide, it is well demonstrated to be teratogenic in animals. It is contraindicated in pregnancy, particularly the first trimester. So this is just a repetition. Calcineurin inhibitors are safe, but increased dose is required during pregnancy. The levels have to be monitored very frequently. Azathioprine is safe. It is associated with dose-related myelosuppression in fetus. So whatever minimum required dose should be given. And corticosteroids are safe. Mycophenolate, there is a risk. It should be stopped at least 6 weeks prior to conception. And just to note, a male patient who is going to be the father of the child, there is no risk in using MMF. It's only for the pregnant mother. Sirolimus, associated with fetal mortality and decreased fetal weight in animal studies. It is contraindicated in pregnancy and it should be stopped 6 weeks prior to conception. Labor and delivery, there is no limitation. A patient can go for vaginal delivery, but because it is going to be a complicated case and a precious pregnancy, because of obstetric indications, cesarean section is preferred. During labor, the stress dose of steroid should be given for the lung maturity of the fetus. That is to be decided by the gynecologist. And contraception, unplanned pregnancy is a risk. So contraception counseling should be given to a post-transplant women of the reproductive age group. And the contraceptive counseling should start even before transplantation. So methods, we can give combined pills, and surgical methods like tubal ligation can also be given for patients who have completed their families. And a small note on breastfeeding. Breastfeeding should not be discouraged for women on prednisolone, azathioprine, cyclophosphamide, and tacrolimus. There is limited clinical information for MMF, sirolimus, everolimus, and belatacept. However, we'd have stopped all these drugs during the pregnancy, so it is better not to restart them until the phase of breastfeeding is over. So to conclude, so the recommendations for renal transplant recipients, at least 6 months after transplantation, but the safe period is more than 2 years. And the patient should have a stable allograft function with a creatinine of less than 1.4. There should not be any recent episodes of acute rejections. The BP should be well under control, less than or equal to 140/90 millimeters of mercury. And there should be no or minimal proteinuria, less than 500 milligram per 24 hours. Prednisolone dose should be less than or equal to 15 milligram per day. Azathioprine less than or equal to 2 milligram per kg per day. And MMF and sirolimus should be stopped 6 weeks prior to conception. So there should be a proper counseling and a multidisciplinary approach. We should have talked about contraception. We should have talked about planning the pregnancy. And even 6 months before, the changes of drugs should have been made. A small note on vaccination pre-pregnancy. It actually, post-transplant, it's a contraindication for most live attenuated vaccines. So rubella vaccine should be given before transplantation in a reproductive age group patient. And in post-transplant setting, inactivated vaccines starting at 3 months post-transplant should be given except influenza. And COVID-19 vaccine is also recommended for transplant patients. So thank you.
Thank you, madam, for going through that talk on pregnancy post-transplant, and you have completed in time. We'll leave to the panelists. Dr. Umavati sir, your comments, please, your experience on post-transplant transplant pregnancy.
Yeah, I agree. I agree that the counseling should start before the pregnancy, before the transplant also, because most of the people who are just married, we have to be very, very careful. The contraception, especially in a lupus, I think we should avoid estrogen pills. Otherwise, we have seen activation of lupus with estrogen contraceptive pills. So we have to be careful and it should be planned. You can use a barrier contraceptive, no problem. And we preferably at least a year after the transplant only, we advise them. And the prednisone should be minimal, less than 10 grams. And also the mycophenolate, we change it at least 3 months prior, even though it's 6 months. So, and there is no rejection in the last 6 months. So the stable graft, more than a year, we advise them for a transplant. So, but the problem is the tacrolimus level goes down. So we have to be very, very careful in maintaining in the first trimester and even the early second trimester.
Thank you, sir. What is the creatinine, maximum creatinine you have seen people getting pregnant after transplant?
We usually go 1 to 1.4. More than that, we advise little bit risk. But again, it's very difficult. We went ahead with 1.8 also, and a lady came with 1.9 to 2 creatinine. It's accidental, so we didn't want to advise them for things, but will require. But she continued with the same creatinine. It in the first trimester, in fact, she was happy looking at the creatinine, which came down to 1.3. So. Yeah. It is again 1.8 is the thing which we went ahead, but otherwise we tell them that it will be a problem for the graft and also the mother and the fetus. We advise them to terminate.
So 1 point up to 1.8.
1.8 we went ahead. So again, it was with the discussion because we explained them the risk of hypertension, proteinuria, graft dysfunction, everything. So the mother-in-law was very, very stubborn and they wanted a child. So we could not help it. The pregnancy was complete and they were happy.
Fine. Was there any improvement in graft function post-pregnancy?
No, in the post, it came back to 1.8, 1.9. But in the first trimester, you know that because of the volume, it came down to 1.3. And because she came with 1.3, the mother-in-law was the renal function is better. So you need to continue. So.
Dr. Ram, your comments, please. And what is your maximum creatinine your patient had around for a pregnancy?
So it's always a very, very tough, right? When we see pregnancy in a transplant, it's not as easy as going by guidelines says. Our experience is not that great. We had a terrible case recently when the patient went ahead with the pregnancy despite our advice not to continue it. Maybe her creatinine was around 1.6. So she thought she can carry on with the pregnancy without any trouble. It all started in the third trimester, and from there on, within 6 months of delivery, she landed up in again back to dialysis. So despite all the efforts going by the guidelines and all that stuff, we couldn't do much for her. And there are reports of successful pregnancy also. We had one successful pregnancy so far. So my experience is only limited, but we are always very wary in handling pregnancy in transplant individuals.
Yeah. Now, from the panelists, the question is...
Recently, we had a lady, she is again 3 years post-transplant, and she was having recurrent urinary tract infection after the marriage. She married after the transplant. So we were worried. She conceived. Now she has completed 7 months. I was worried that because she had a lot of urinary tract infection prior to, after the marriage, but luckily till 7 months, everything is fine. She is doing okay. She was on everolimus, which we stopped because there is no limit. There is limited data.
For the panelists, what is your take on allowing pregnancy for a high-risk transplant like HLA sensitized or ABO transplant? Do you allow pregnancy after 1 year even with a stable graft? And there is a risk of switching over from MMF to azathioprine in such kind of patients.
I think the ABO incompatible transplant may not be high risk because even after a month or 2 months, unless there is a DSA. So if there is a DSA high risk, then we have to be very, very cautious in reducing immunosuppression.
Even with normal graft function, no uneventful post-transplant period, and you won't allow.
It's a tricky decision because if there is a significant antibody, we don't monitor the antibodies every time. So if you, again, best is to, somebody asked a question also, okay, whether you need to check the DSA before shifting from MMF to azathioprine. If the pre-transplant, we do pre-transplant DSA in everyone. So if there is no DSA pre-transplant, and if there's a graft function was completely normal, we don't advise a DSA pre-transplant. If there is any rejection before the pregnancy, I think we may take a call to check the DSA so that a reduction in the immunosuppression may create a rejection episodes because it's an immunomodulatory state. So we may have to check the DSA, but sometimes it is very difficult. They come with the pregnancy, you can't do much.
history of rejections in early post-transplant period, later becoming stable graft function. What is your take on allowing pregnancy for such kind of patients?
At least 6 months, they should be stable. There should not be any rejection in the last 6 months.
Okay. And one question has been answered that how long what is the time frame for switching out to associate prime with MMF to associate prime? It's 6 weeks. Actually answered. And I don't think so. I see one other yet another question. Like, how do you suspect AKI? Creatinine dips during when to suspect AKI during the pregnancy post-transplant. Does the same criteria apply as for the normal pregnancy?
It's again same.
Okay.
Because it comes back, but the third trimester only creatinine come back to normal. So after the pregnancy is over, again, it will remain the same. If there is an AKI, there should be 25 to 30% increase.
Okay. So I had a fortunate of allowing 2 pregnancy of my patients, and both of them went well. And it's all depend upon the graft function and image status.
We had unfortunately, we had miscarriages also, and even just before the patient was planned for a cesarean section, and 2 days after that, she had an IUD, and then we had a lot of problems. Patient went into depression. So it's a lucky patient should be lucky, and the doctor should be lucky.
Okay, sir. So treatment of rejection during transplant and during pregnancy is same as for the normal individuals, right, sir?
Even rituximab, people have seen when they have a flare-up of lupus, people have given, and there is no significant transfer of rituximab. So you can give it. There is no leukopenia or anything which happens in the pregnancy. Again, it should not be the first option. When all other options are this, then you can go ahead and give rituximab also.
Fine. Okay. And if there are no further questions, there is another question is there, and you could see experience regarding recurrence of renal native disease after abortion in a post-transplant mother.
Recurrence of disease.
Recurrence of native disease after abortion.
I don't know what he's basically. If there is any lupus or anything, then yes, there is an activation you see. But again, after the abortion, usually it increases with the pregnancy. We have seen the lupus activation when they become pregnant. So we had recently a lupus lady. She had COVID, and then she had lupus positive, but like in the pregnancy test was positive. We did an abortion, and everything improved after that. So pregnancy is a state which activates, but again, abortion, I really don't know whether it will increase the native kidney disease recurrence.
Okay, thank you. There are no further questions. It is a happy meeting. It was overall a good informative meeting. And we first dwell into the case of post-renal transplant, post-transplant lymphoproliferative disorder managed with vincristine that ultimately resulted in vincristine-induced acute neurotoxicity. Ultimately, patients succumbed to the sepsis. And the point we learned, like, suspecting the complication of the drug when something happens to the patient while on the drug, and interactions. Be careful on the interaction of drugs which is causing the problem, and regular monitoring of TAC and all everything is very important. So second is about the pregnancy and post-transplant pregnancy. We have learned some important tips and to be given to the patients who are going to be pregnant after transplant. And thank you, both the speakers, for letting us know some important insights into the cases, complicated cases. And thanks for the painstaking presentational preparation and presenting to us. And thanks once again for the panelists, Dr. Umapati Ekdesar and Dr. Ram Prabhakar, for sharing their time and inputs to make this session lively. And as always, we thank our delegates who have been attending regularly for this meet, and in spite of the busy work and encouraging us all along for the past 4 years. And I must thank the MQ team for giving us this media for the technical support. And the next month we'll be having the meeting on the first Saturday. And we invite the institutes all over India to come forward to present the cases so that we can learn from each other. And these kind of cases will give us a lot of insights rather than taking from textbooks or like that. And thank you once again for the active participation. And thank you one and all for the meet. Thank you.
Thank you. Thank you, Rajrajan. And
Thank you,
thanks
sir.
the peculiar team. And thank you very much for the opportunity. We enjoyed.
Thank you, sir. Well,
Thank
sir,
you.
thank you.
Thank you,
well,
Raj.
sir.
Well, sir, namaste. Thank you.
Thank you. Thank you very much.
Thank you.
Thank you, Rajrajan, sir. Thank you for the opportunity.
Thank you, madam. Thank you, madam. Thank you.
Thank you, Raj.